Welcome, everyone, to our presentation on the Quality Measure Audit Review for the diagnosis of schizophrenia. Today, we will delve into the critical aspects of assessing and enhancing the quality of care provided to individuals diagnosed with this complex mental health condition that can trigger a quality measure audit. Schizophrenia, as we know, affects approximately 1% of the population worldwide and is characterized by profound disruptions in thought processes, perceptions, emotional responsiveness, and social interactions. By the end of this presentation, we aim to foster a comprehensive understanding of how quality audits can drive better clinical practices and review, first, regulatory guidance and OIG findings, second, how CMS audit process is completed, third, how a schizophrenia diagnosis is met, and fourth, how to avoid losing your star rating under Care Compare. Our focus is on enhancing our understanding and improving our practices by identifying the regulatory basis for the CMS audit process. Second, describe the steps in the audit process. And third, describe how to correctly code schizophrenia and schizoid affective disorder. QSO 22-19, released on June 29, 2022, serves as a significant guideline within the Scope of Operations Manual, SOM. This document was issued as a preview to upcoming audits, highlighting crucial updates and expectations for compliance. The guidance outlined in QSO 22-19 aims to ensure that healthcare providers adhere to the latest standards and protocols, enhancing the quality of care and operational efficiency. As a prelude to the audits, it provides a framework for facilities to prepare adequately and align their practices with regulatory requirements. In 2016, Center for Medicare and Medicaid Services initiated focused schizophrenia on-site surveys to address the issue of erroneous coding of schizophrenia in nursing homes. These surveys identified facilities with patterns of misclassifying residents with schizophrenia. To further tackle this problem, CMS will start conducting off-site audits to evaluate the accuracy of minimum dataset or MDS data. These audits will review the facility's documentation, assessment, and coding of schizophrenia diagnoses in the MDS for their residents. CMS conducted pilot audits to test the MDS audit process and uncovered several issues with the coding of schizophrenia. These issues included the absence of comprehensive psychiatric evaluations and behavior documentation, with many residents exhibiting behaviors related to dementia rather than schizophrenia. This initiative aligns with CMS' goal to reduce unnecessary antipsychotic use and enhance the accuracy of quality measures and the 5-star rating system. Released on November 14, 2022, the Office of the Inspector General, or OIG, reported that from 2011 to 2019, around 80% of Medicare's long-stay nursing home residents were prescribed psychotropic drugs. During this period, while CMS aimed to reduce the use of antipsychotics, the use of anticonvulsants rose, leading to a consistent overall usage of psychotropic drugs. In 2019, nursing homes with lower ratios of registered nurse staff to residents and those with higher percentages of residents receiving low-income subsidies were found to have higher use of psychotropic drugs. These findings suggest that specific nursing home characteristics significantly influence the prevalence of psychotropic drug use. When CMS conducts an audit, the targeted provider or facility will first receive an email notification via the IQIES system, typically addressed to the MDS coordinator. This email will inform them that their facility has been selected for a schizophrenia probe. Following this email, a formal letter will be sent directly to the facility. Prompt action is crucial, as a timely response within 48 hours is required to avoid defaulting to a 1-star rating in the quality measures of the Nursing Home Care Compare system. It is essential that the facility begins gathering the necessary access information immediately upon receiving the email, rather than waiting for the formal letter, to ensure compliance within the 48-hour timeframe. Please be aware that the letter or email will include several attachments. First, Attachment A is a facility survey. Attachment B is a checklist of requested supporting documentation. Attachment C is a web portal user account request instructions. And Attachment D is the web portal instructions, while Attachment F is a form in which you can list of users for the web portal, along with their IP addresses. These attachments can be overwhelming and confusing, and we will address them in detail in the following slides. Once your facility receives the notification letter, quickly scan the attachments. On the first day after receiving the email, your facility should focus on completing attachment D and F. This document, once completed, enables your facility's users to access the CMS portal for uploading and viewing requested documents. It is crucial to complete and submit this document promptly, as this process takes 48 hours. Note that this request for access does not start the actual probe time. The 48-hour countdown begins when you receive the notification letter via mail. In cases where the mail is delayed, the auditor may send a notification email to start the 48-hour countdown. Instructions for Attachment D's Web Portal. 1. Use Internet Explorer. This browser provides better visualization of the portal. 2. Avoid Chrome. Chrome may block essential information you need to see. 3. Multiple users. Consider having multiple users able to submit documents. 4. Email verification. Ensure you have email verification for access before the initial conference is held. 5. Read instructions. Thoroughly read the entire instructions on how to access the web portal for uploading documents. Finally, the instructions also provide information on how to get information if your facility needs assistance and how IT support number and/or email in the web portal instructions attachment. By promptly addressing these steps, your facility can efficiently manage the audit process. Next attachment your facility needs to complete is Attachment A, Facility Survey. The Facility Survey attachment should be completed within 24 hours, the same time frame as Attachment D and F. This checklist includes information on how your medical records are stored. You need to provide details and indicate the type of medical record storage system used, such as electronic medical records, manual storage, or a combination of both. Next, let's look at Attachment B. Attachment B contains a list of documents requested for specific patients. This includes essential information such as the minimum dataset, face sheet, and psychiatric evaluations. It is crucial to provide these documents promptly to ensure compliance and facilitate the audit process. On day 2, after completing the facility survey, review Attachment C for the requested supporting documentation checklist. The due date for these documents is the second business day following the delivery date of the certified letter from the United States Postal Service. Given the sensitive nature of the requested information about your residents, you must upload the documents to CMS Secure Web Portal. To set up a user account, fill out the Web Portal registration form included in the mailing in Attachment F. Follow the form's instructions to obtain your IP address, ensuring you include only those contacts who need to upload or download documents. Email the completed form to CMS. After submitting, you will receive an email when your IP address is approved, which may take 1 to 2 business days. Once your account is finalized, you'll get a subsequent email. Refer to previous slide for Attachment D for instructions on accessing Myers & Stauffer's secure web portal after receiving the account approval email. Myers & Stauffer is the contracted company that CMS enlists to complete this type of audit. After submitting the required documents to access the secure web portal, your facility will be scheduled for an entrance conference. This entrance conference is conducted after your facility has had the opportunity to self-report any errors to CMS. The self-report should include the percentage of errors in the diagnosis of schizophrenia. CMS will then decide whether to accept or reject your self-report. If the self-report is not accepted, the facility will undergo a further audit. If the facility opted not to self-report, the nursing home administrator must sign a letter attesting that there were no errors in coding. If the facility chooses to self-report, a repeat audit will be conducted, and continuous access to additional medical records and additional document requests, or ADR, will follow. After submission and completion of the audit, the facility can request an exit conference. Remember that the auditor may not do an exit conference. It is recommended to request one at the entrance conference, so you and your facility can understand the corrections to be made if you did not pass the audit process. Remember that another follow-up audit may occur as part of the monitoring process. The patient list will be sent via email and also uploaded to the secure website system you have requested access using Attachment T of the notification letter. Please review the patient list to determine which requested documents you need to provide. Additionally, following the Entrance conference, the list of residents and required documents will be emailed to you. Please note that your facility has the option to provide remote access to your EMR if preferred. However, you may also choose to upload documents instead. If you opt for uploading documents, the auditor may send an email requesting additional documents if any information is found to be missing. You have a 2-day window to upload all required documents if you have chosen to upload documents in the secure website. If a new list of documents is requested, a new deadline will be provided. The auditor may request a new set of documents to complete the audit process. In such cases, if you choose to upload documents, a new timeline and submission deadline will be established. And finally, documents requested. In the next slide, you will be able to review the list of documents you have to provide. During the audit process, the requested documents include the resident list, which encompasses admission records, and the most recent submitted MDS assessments. Specifically, the initial MDS assessment coded under Section 1-6000, indicating a diagnosis of schizophrenia, should be provided. Please also include any MDS assessments aimed at correcting inaccuracies related to this diagnosis, if applicable. A diagnosis listing, reporting for the resident list, will also need to be provided, as well as a current listing report of any residents currently in the facility with schizophrenia diagnosis. During the document review process, additional information requested includes medication administration records, a 7-day retrospective view of the minimum dataset, or MDS, and any behavioral monitoring documented within the MR. Also required are behavioral summaries, history and physical reports, progress notes, nurses' notes detailing observed behaviors, Maryland progress notes indicating the diagnosis, and medication orders for psychotropic medications. These documents collectively provide comprehensive insight into the care and management of behavioral health issues and medication administration protocols. The behavioral assessment must include behavioral health records or practitioner assessments, as well as admission records and the most recent comprehensive medical and psychiatric evaluations conducted at the time of the initial diagnosis of schizophrenia. A comprehensive reevaluation should also be documented to confirm the diagnosis of schizophrenia. Please ensure that before coding the MDS assessment, you verify documents that provide backup documentation based on the assessment reference date, ARD. Lastly, the facility must furnish any additional documentation supporting the use of antipsychotic medication and/or the diagnosis of schizophrenia. This includes items such as notes from behavioral meetings, nurses' notes documenting behavioral issues, and records from social services or psychology. Furthermore, documentation confirming completion of pre-admission screening and resident review, PASR, at levels 1 and 2 is also required. These documents are essential for ensuring thorough evaluation and appropriate management of schizophrenia and related conditions within the facility. Failure to respond to the audit or to comply within the specified timeframe will result in a reduction of the star rating to 1 star. Additionally, a notation of 20 will accompany the Quality Star Measure report, signifying that the facility's data could not be verified through the audit process. These outcomes underscore the importance of timely and thorough participation in the audit to maintain accurate quality assessments. Facilities identified with coding inaccuracies during the schizophrenia MDS audit will undergo specific adjustments to their quality measure, QM ratings. 1. The overall QM and long-stay QM ratings will be lowered to 1 star for 6 months, leading to a corresponding decrease in the facility's overall rating. 2. The short-stay QM rating will be withheld for 6 months. 3. The long-stay antipsychotic QM will be withheld for 12 months. These adjustments aim to uphold the precision of QM evaluations and illustrate the repercussions of coding errors on quality measures over defined periods. And for facilities where consistent coding inaccuracies have been identified, whether through an audit or during admissions, CMS will closely monitor each facility's data to assess whether the issues have been rectified. This evaluation will determine if any downgrades or suppressions imposed on quality measure, QM ratings, should be lifted within the specified timeframes mentioned earlier. Additionally, there may be a follow-up audit to confirm that the corrective actions have indeed addressed the identified issues. These measures are intended to ensure ongoing compliance and accuracy in reporting within healthcare facilities. As per the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, the conditions within the schizophrenia spectrum include schizophrenia itself, schizotypal personality disorder, a subtype of personality disorders, delusional disorder, brief psychotic disorder, schizophreniform disorder, and schizoaffective disorder. Additionally, catatonia manifests as a syndrome characterized by symptoms such as immobility, abnormal movements, repetitive behaviors, mutism, and social withdrawal. Catatonia can occur independently or complicate various psychiatric and medical conditions, including schizophrenia. The criteria for diagnosing schizophrenia include several key aspects. Firstly, individuals must exhibit at least 2 of the 5 primary symptoms: delusions, hallucinations, disorganized or incoherent speech, disorganized or unusual movements, and negative symptoms. Secondly, these symptoms must persist for a minimum of 1 month. Additionally, the broader effects of the condition, regardless of whether they fully meet the symptom criteria, must endure for at least 6 months. Lastly, there must be evident social or occupational dysfunction, indicating a notable disruption in either work functioning or interpersonal relationships, encompassing friendships, romantic connections, professional engagements, or other social interactions. These criteria collectively define the essential elements required for a schizophrenia diagnosis. Schizophrenia progresses through distinct stages. 1. Prodromal phase. This initial stage precedes the onset of severe symptoms and may include social withdrawal, anxiety, reduced motivation, and neglect of personal hygiene. 2. Active phase. Also known as a psychotic break, this stage marks the onset of full-blown psychotic symptoms. During this phase, individuals typically exhibit at least 2 of the 5 primary symptoms listed in the following section, indicating a significant detachment from reality. Lastly, and third, residual phase. Individuals in this stage exhibit lingering signs and symptoms of schizophrenia, although they are less severe compared to the active phase. Common characteristics include unusual beliefs, reduced motivation, diminished capacity for pleasure, limited speech, and decreased emotional expression. Many individuals experience periods of improvement where they appear mostly or fully recovered. However, these periods are typically temporary, and symptoms of schizophrenia often recur when the person returns to the active phase of the condition. When addressing the complexities of managing schizophrenia and schizoaffective disorder within healthcare facilities, it is crucial to establish robust protocols for accurate diagnosis and documentation. Ensuring precise recording of patient data in the minimum dataset, MDS, is essential for effective treatment planning and quality care delivery. This introduction sets the stage for exploring how facilities can conduct thorough self-audits to maintain compliance and accuracy in MDS coding. Identification: facilities should conduct a comprehensive report on all residents diagnosed with schizophrenia or schizoaffective disorder. This involves identifying when these diagnoses first appeared in the minimum dataset, MDS, including the initial assessment at admission, the most recent MDS assessment, and any interim assessments between these periods. Self-audit: perform a thorough self-audit to pinpoint the first instance of an MDS assessment coded under Section I-6000 with a diagnosis of schizophrenia or schizoaffective disorder. Review medical records from the past 6 months to document persistent behavioral indicators. Additionally, verify the presence of a comprehensive psychiatric assessment, indicating a reassessment of behavior as fitting the criteria for schizophrenia or schizoaffective disorder. Error rate: calculate the error rate associated with MDS coding accuracy. Develop and implement an action plan tailored to prevent future occurrences of MDS coding errors. Consider implementing random audits throughout the year to ensure ongoing accuracy. Modify MDS entries promptly upon discovering any inaccuracies to maintain precise and reliable documentation. Complete all 3 steps so you will be ready for when you get an audit. Here are 3 key takeaways from the discussion. Importance of accurate documentation. Ensuring precise recording of schizophrenia and schizoaffective disorder diagnoses in the minimum dataset, MDS, is crucial for effective patient care and treatment planning within healthcare facilities. Significance of self-audit practices. Conducting regular self-audits helps facilities identify and rectify any discrepancies in MDS coding. This process ensures compliance with regulatory standards and enhances overall data accuracy. Enhanced patient care outcomes. Implementing rigorous self-auditing practices not only supports accurate diagnosis and documentation, but also contributes to improved patient care outcomes by facilitating informed decision-making and treatment strategies. Thank you for joining us in this learning presentation. We hope to see you again in another training module.